So hello, I would like to introduce ourselves. We are from DWH Simulation Services, which is a spin-off of the Vienna University of Technology. We're still finishing our PhDs there and have a strong connection to the university. My company does many public research projects, and we today want to talk about the research that we do together and for the social insurance of Austria. So, the social insurance in Austria, of course, they have a lot of data, which is routine care data, because they do the reimbursement of the healthcare providers, and automatically they get a lot of data on drugs, the drugs prescribed, the services performed by the doctors, also the diagnosis, for example, in the hospital sector. And they want to have tools to use this data. Of course, their statistics comes to our mind, also other data analysis techniques, and also modeling. The benefit of routine care data is that it's pretty easy available. So, of course, not for everyone, but for the social insurance, it's not an additional big effort to gather these data. So our simulation models should, of course, use this data as much as possible to be as accurate as possible. And I have to go along with the speakers before that. We also work a lot with R after our AnyLogic models to do the post-processing, so an interface would definitely be a great thing. And we today want to show 3 different examples and where we use this routine care data in them and how we did it. So the first thing is the social insurance thinks about different reimbursement systems. And today in Austria, we have, in the outpatient sector, a reimbursement system where physicians are generally paid for the single services they do. So, but the social insurance thinks also of other reimbursement systems, more capitation-based like systems, where you would pay a certain fixed sum per patient, per reimbursement period, or per episode of care, maybe depending on the disease. So the objective in this case was can we do a model where we use the data and where we can compare different reimbursement data and what would happen if these different reimbursement systems would be implemented. So we had to think, how would we imagine this problem and try to take objects that are also found in the database. So of course there are patients, because in the database that we had from the social insurance, there are reimbursement claims of every patient. So it's not linked to their names, of course, because of privacy reasons, but it's linked to single patients, all the different claims from drugs, services, and also the hospital data. And on the other hand, we have the medical providers, because we also know from the data at which medical providers were the services performed. And then we had to think, why takes reimbursement place? Why is it done? Because patients develop medical problems, diseases, and because of these medical problems, they consult the medical providers. So they visit them, and from the providers, they will get medical services, which we would then find also in the reimbursement database. And of course, the providers then get paid because of what they did and because of the patient visits. So from the payers, in the case of Austria, this would be the social insurance. And the reimbursement, of course, depends on the different reimbursement systems. So is it the actual reimbursement system that is used now, or would there be a different reimbursement system? So in the model, which we did in AnyLogic, you can find these objects for example, the patients, which are on the left side. So here, you can find the patients. We have different medical provider types because we have different data on the different specialties. And for each specialty that we have also in the data, and in Austria, I created an own active object, but it's all the same medical provider class, but with a type parameter, and yeah, so some attributes of the provider would depend on it. So this is here. And because we have a lot of data in this model, and I will show you then how it's read into the model. There are a few functions there on the right side where we read prevalences, incidences, how many patients are there in which age groups, how many medical providers are there, which services do they offer, and which services will patients get according to the medical problems they come to the provider. All these things are read into the model in this place. Yeah, and the reimbursement system thing, we want to exchange the reimbursement systems, so it should be generic. And there is this abstract type, so just a Java class for reimbursement system, which describes what a reimbursement system should be able to do in general, which is pretty much that it takes wizard objects. A wizard object would hold all the information that a possible reimbursement system could use. So provider ID, patient ID, so that we know from which provider and patient was it, then the date and the services that were performed, and the diseases, because a single service system calculates the reimbursement because of the single services, of course. A capitation-based system that is disease-dependent would calculate the reimbursement because of the diagnosis. And so if you want to use another reimbursement system, just implement one and then change the reimbursement system in the model. Yeah, so different data was used and gathered from the routine care database. So there were data also from public statistics, for example, the population, and from the routine care database where we calculated the prevalences of the diseases, the incidences, and also which services were used. There is more information on this in the publication, the conference publication, which I've printed on the slide at the bottom. And all is put together in an Excel file. There are about 20 worksheets, and they read into the AnyLogic model at the beginning. So we had a lot of agents in this model. Austria has about 8.3 million inhabitants. We used a scaling factor of 1 to 10, so that we have 800,000 agents. A higher scaling factor where we would have fewer patients would have been problematic because there are medical specialties where there are not so many providers, and if you scale everything in the model, then you would end up with too few providers in a few specialties. So this put large memory requirements. The speed was not a problem, a quarter of an hour or a half of an hour, but the memory requirements are about 3 gigabytes for this scaling factor, and so we really needed the 64-bit version of AnyLogic for this. Yeah, we've also tried to incorporate GIS information into this model, but with different providers, because we took the hospitals for this. It was a thesis of a master's student. We just tried it so far, and he wrote another class for using PostGIS, PostGIS data in the model. Then the second example is also for the social insurance. They wanted to know what would happen when group practices would be implemented. So group practices where doctors from different specialties would work together. So the problem is that In this case, we looked at two specialties, the internists and the pulmonologists, and there would be two providers which go together in a group practice and which are potentially paid in another way, and we wanted to know what would happen. So in this case, we did a system dynamics model, and our view of the problem in this case was that we have, on the one hand, the cases. So a case is if a patient goes at least once in the reimbursement period in 1 quarter to the provider, then he has a certain amount of consultations, maybe just 1 time, maybe 3 times in this quarter of year. And from the consultations, for every consultation, he gets individual services. And this leads to reimbursement. In this case, we included feedback explicitly from the reimbursement because according to the workload and to the salary would the providers adapt and maybe heighten or lower their services per consultation and so on. Yeah, in this case I used heavily array variables because basically you have the same structure for 4 different groups, the 2 doctors that would go together, the internist and pulmonologist, and all the other ones which stay as single doctors. And they have the referrals between, so there is some sort of interaction between them. So then in the implementation, I also used active objects to make it like a modular structure and use the ports between them. Yeah, in this case, the output of the model would be the total fees that were paid, the cases, how many consultations over time, and in the input, in this case, we made it different. We did not gather the data ourselves, but we gave the parameters that the model would need to the social insurance, and they would make the data analysis themselves and would send us a file with all the parameters. These are here at the bottom, and then we try to separate the different assumptions in the model. So we would want to talk to them we talk to them that there is this fixed parameterization that we wouldn't change, but there are also strategic assumptions, which would be how much would they reimburse in the group practice, which tariffs would they do, or system assumptions which they could change over so that they would look at it at different scenarios. So the next example is presented by my colleague.
Okay, so I'll present now the modeling of abdominal aortic aneurysms. So abdominal aortic aneurysms is a dilatation of the abdominal aorta of a person. Usually the abdominal aorta is about 2 centimeters in diameter, and when it gets bigger and grows, the rupture risk of a person increases as well. And if it's large enough, so usually when it's above 5.5 centimeters, the rupture risk is so high that surgery is considered. Also, surgery itself is very dangerous. We know that in Austria, about 1/4 of the people who get surgery die. So about 6% of all Austrian male people who are aged 65 years suffer from an AAA, and the incidence is much lower amongst women, but also the incidence is lower amongst women. It's only 1/4. The rupture risk is increased for them. For detection, ultrasonography is used. Sensitivity and specificity is very high. It's almost 100% for both. So it's a cheap way to detect it, but it's not routinely performed right now in Austria for the elderly. And the research question was, what would happen in the Austrian population if organized screening for 65-year-old persons was introduced compared to the current practice. So currently, there's just incidental detection. Then there was also the question, which people benefit the most from organized screening. So we know from the routine care database, which was already presented by my colleague, that we have lots of different other diseases amongst people, so cardiovascular diseases like diabetes or other things like not only diseases but also smoking habits, for example. So also other risk factors that increase both growth rate of an abdominal aorta as well as the rupture risk. So we had to model both the whole population as well as the individual growth of the abdominal aorta within a person. That's why we chose an agent-based approach in AnyLogic, where each person has its own aorta, which grows, the growth is modeled by differential equation. Well, in this case, we use system dynamics where the diameter growth is dependent on age, sex, changing smoking habits, past diseases, and also the natural history of the AAA. So in the end, they also wanted to know what are the optimal screening strategies. So the classical approach from original screening, like proposed by UNIT HDA, is just screening once with 65 years, and then people who are detected, who have then detected AAA, will be screened again annually, but other people won't be screened ever again. So we also had the question, or wanted to answer the question, can we change the screening scheme? For example, is it better to screen certain risk groups more often and other people less often? And also the timing window, so is it really necessary to screen annually, or is it better to just screen every 2 or 3 years and increase the screening schedule when people develop other risk factors? So this is an overview of the main class in AnyLogic, where we have, well, parameters and functions for the initialization, for the treatment, for AA development, and population initialization. We tried to make the framework which we used as modular as possible, so that, for example, if we want to try another screening strategy, we just have to change certain things within the screening object. So when we now performed the analysis, we had certain outcome measures. One, the most important were the rest life of the patients, so the years that were gained by screening, then the deaths amongst AAA patients, and of course, in this case, the ICER, so the incremental cost effectiveness ratio in terms of cost per life years gained. So what we can see here is that, of course, the screening participation rate is very important for the outcome, but that isn't really a problem because, well, there is the assumption that about 40% will go to screening, and, well, the overall cases are about 600 to 800, so if we have plus minus 50, that's for such an HDA question not really a problem. It's not, so the sensitivity is sufficient to answer our question. To the results, the blue line shows what happens if we just follow the current practice in Austria, so the amount of ruptures which will occur. And if we introduce screening with about a 40% coverage rate, it will be reduced by about 1/3. And like I told before, rupture usually ends with the death of a patient, because at least like we know also from routine care database, about 80% of the people with a rupture who are not treated immediately die because of AAA. So because we also included other risk factors like smoking cessation, we also tried to find out whether other interventions than original screening have a similar effect or even a better effect than the introduction of a screening program. In this case, on the right side, we can see that smoking cessation well, in Austria, about 38% of the population are smokers. If we reduce them to about 20%, then it would have the same effect as the original screening program. So, coming to the conclusions of our talk, routine care data is really a valuable source, especially when using agent-based simulation, because usually routine care data is on patient level. So we don't have, like when you get study data, it's usually aggregated data, which has to be broken down to single persons if you want to parameterize an agent-based model. But in this case, we really have already data on individual level. Then it's really important that we have to think about where we want to use this routine care data, because there are certain examples where it can't be used, especially when assessing new technologies which can't be found in the database. And another thing is how many aggregation is really acceptable. Because, as we said, in the routine care database of patients, we don't have healthy people who never get any treatment. So the further work we want to do is we now aim to get a project where we really analyze pathways of patients, so that, for example, in the reimbursement system example, we can integrate the ways of the patients and really to which providers they go, not only on a map, but also in which time frames and so on. And another thing is that we want to extract causal relationships out of routine care data, because usually you just look at correlations, but every time when we want to use a system dynamics model, it's also important to know where the causal relationships have to be linked. So thanks.